now we'll have the second lecture, which is connective tissue disease-related pulmonary hypertension, early management.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much. Now, as you know, this lecture was supposed to be given by my friend, Dr. Abdullah Dalan, but for technical issues, he was unable to make it. So now I'll be talking about the management of CTDs, pulmonary arterial hypertension. And when we start treating those patients, we go from step to step. So basically, we start by establishing the diagnosis, as we said in the previous talk, by echo and then right heart cath, and then by some blood tests. We determine the classification group, and here for this talk, we're talking about group 1. We evaluate the severity of the disease by many endpoints that I'm going to talk about quickly. We get different treatment option and then trying to achieve the goal. And just before I start, I'd like to emphasize that treating pulmonary arterial hypertension is different than treating many other clinical diseases. For example, when we treat systemic hypertension, we have a specific target to reach. Similarly, when we treat diabetes, you would like hemoglobin A1C to be less than 7. However, when we treat PAH, do we really need to drop the pulmonary artery pressure? And the answer is no, because really dropping the pressure per se will not lead to any prognostic improvement in the outcome of the patient. And comparing the prognostic significance of basically pressure compared to other parameters such as function class or cardiac index or 6-minute walk distance, changing the pressure has the least prognostic significance. So the question is then, what is the target of therapy? And the target of therapy is to get the patient into the green zone, and that built on composite endpoints, including the symptoms, exercise, biomarkers, imaging, and hemodynamics. So we'd like the patient to have minimal symptoms. We want them to be in function class 1 or 2, no syncope, no RV failure. Would like them to have good exercise tolerance, being able to walk for at least 440 meters. You would like to have them to have normal or close to normal biomarkers, looking for NT-proBNP less than 300, good imaging by echo of right atrial surface area less than 18, no pericardial effusion, and high TAPC scoring. And we need to have a good hemodynamics. When you have right atrial pressure is low, good cardiac index, and good mixed venous oxygen saturation. So really the target, as you can see, none of those talking about the pressure. The pressure was good only for diagnosis. It has no value whatsoever when it comes to the goals of therapy. And the first person to start talking about this goal-oriented strategy was Maris Hooper from Hannover, Germany. When he had that strategy to say that I'd like to reach targets. And the target they used in that study, that was about 15 years old now study, that they wanted 6-minute walk distance more than 380, oxygen consumption more than 10.4, and systolic blood pressure more than 120. And he kept adding medication, even if the patient is doing very well clinically, but not at target, they would continue adding medication until they reach that strategy. And they found out by doing that the outcome was much better than our previous strategy when we used to use only one drug, waiting for things to really deteriorate before adding another drug. So, and when you look at how did that work, looking at this green, yellow, and red zone, this was the French registry showing that patients who fulfill the 4 criteria, including the symptoms, echo, biomarkers, and hemodynamics, they do much better than those who really achieved only 3, 2, or 1, or no criteria whatsoever when the outcome became so miserable. So really, the bottom line here is to reach as many criteria as possible to say that now my patient is at target. So when we start treating those patients, we look at whether the patient is in which zone. So those who are, for example, in the red zone, then we start with upfront combination therapy, including IV prostacyclin. Those who are in the yellow or green zone, or even in the green zone, we start with initial upfront combination. Now, the role for monotherapy is become very, very limited, and we might talk about it later on. But depends then on where is your patient in the green, yellow, or red zone. That will determine where would you start. And now when you look at the available treatment to deal with pulmonary arterial hypertension, including CTD, pulmonary arterial hypertension, we have three signals that we are now targeting with our treatment. So we have the prostacyclin pathway that work on the accumulation of the cyclic AMP, which has a very potent vasodilatation, reduction in proliferation, and anticoagulant properties. We have the nitric oxide pathway working on the cyclic GMP that has a very similar mechanism of action compared to the cyclic AMP. And we have the endothelin receptor antagonist trying to block both endothelin A and B receptors on the smooth muscles, leading to vasodilatation and inhibition of the proliferation. When we look at those molecules, the first molecule was used was the IV epiprostenol, and that was in the mid-90s. That was a breakthrough in the field of pulmonary hypertension, where showed that that was led to significant improvement, or actually doubling or more than doubling in the survival for those patients. Now, the problem with the IV prostacyclin that it need indwelling catheter, 24-hour infusion with the pump that might be logistically challenging for the patient. And also because of the short half-life of the drug, if there is any interruption of the treatment, you might have a rebound pulmonary hypertension. So if you put your patient on the IV epiprostenol, which is the best treatment available, we need to be sure that the logistic for having proper follow-up and immediate medical care is available. But because of these challenges, now we have prostacyclin analog looking for the sub-Q treprostinil, which has longer half-life and less cumbersome delivery mode. We have the inhaled ileoprost, and then we have the oral selexipag. When you look at the inhaled, basically ileoprost in the AIR study, inhaled ileoprost was quite effective in patients with group 1 PAH, including CTD, and patients who were treated with the inhaled ileoprost had significant improvement in the 6-minute walk distance, which was the primary endpoint in the previous studies. More recent, at the Griffin study, looking at the oral selexipag, which is prostacyclin receptor agonist, looking at reduction in morbidity mortality, find a 40% reduction in morbidity mortality in patients receiving selexipag compared to placebo. Looking at the endothelin receptor antagonist, the first study was using bosentan in the BREATHE study, showing that bosentan in 2 doses, 125 and 250 BID dosing, again improved the 6-minute walk distance significantly in those patients and reduced the clinical worsening endpoint. The approved dosing came from different regularity agent is 125 BID because of the safety issue, because as you know, bosentan at the higher dose has a higher risk for hepatic toxicity. More recent, the Seraphin study using macitentan in treating patients with group 1 pulmonary arterial hypertension showed that again macitentan at the 10 milligram dose once daily was led to about 45% risk reduction when it comes to morbidity mortality. And when we break down the patient in the Seraphin study, looking at whether those patients who have connective tissue diseases, are they different than others? They were actually doing as good as basically idiopathic and other PAH group, indicating that macitentan work in all CTD categories, PAH category, including CTDs. And finally, we have the nitric oxide pathway. The first study was the super study looking at sildenafil using 3 different dosing, 20 milligram, 40 milligram, or 80 milligram TID, And again, looking mainly for the 6-minute walk distance at the primary endpoint, showed that sildenafil at the 3 different dosing was very much superior than placebo. At the moment, the recommended dose is 40 or 80 TID, because the 20 milligram TID bioavailability seems to be weaning off after 1 year of therapy. And finally, we have Riociguat, which is another nitric oxide molecule working to stimulate soluble guanylyl cyclase enzyme, leading to the accumulation of the cyclic GMP, again, was significantly superior than placebo in improving the 6-minute walk distance in patient who had pulmonary arterial hypertension. One important study that worth mentioning was the Ambition study, talking about whether we should use only one drug as a monotherapy or starting with a double upfront combination. So in this study, they had 2 arms. The first arm used monotherapy of really either ambrisentan as a receptor and endothelin receptor antagonist, or tadalafil as an PDE5 inhibitor monotherapy, versus upfront combination of both medication. And they found for sure that this kind of double combination strategy was very much superior compared to monotherapy in reducing morbidity and mortality endpoints, with about 50 to 60% reduction in the primary outcome. And because of that, many authors were really interested in this combination, and this study that looking at scleroderma patient, 25 naive scleroderma PH patient. This was study was done in many centers. The primary center was John Hopkins. They tried to look at those patients who had PH-CTD, mostly scleroderma, and those patients were treated with a combination of ambrisentan tadalafil, very similar to the Ambition trials. Now, the primary endpoint was quite basically important in this study, because they did not simply look for 6-minute walk distance, because as you can say, that patients with CTDs can have challenges in walking, not because of the pulmonary arterial hypertension, but because of the joint issue. So the primary endpoint came as change in the RV mass as assessed by the cardiac MRI, and change in the pulmonary vascular resistance, but they also look at a change in the pulmonary compliance, 6-minute walk distance, RV ejection fraction, and the pro-BNP. And very interestingly, found that those patients who were treated with upfront combination of ambrisentan and tadalafil, when you look at the PVR, pulmonary vascular resistance, there was significant drop in the PVR in those patients after 36 weeks compared to those patients who were not treated by that strategy. When you look at the RV ventricular mass index, again, there was significant drop, and that again indicating that there was some form of improving in the remodeling process in the right ventricle. The pulmonary capacitance increased significantly, and right ventricular ejection fraction improved significantly after the 36 weeks period, again emphasizing that the upfront combination therapy in patients who have scleroderma PH is beneficial in this group of patients. So my take-home message to you, ladies and gentlemen, that as we said in the previous talk, PH-CTD usually carry a very poor prognosis, and you don't want to have that combination in your patient. And this is why we need to do everything possible to detect that combination very early in order to improve the outcome in those patients. As we said, the pulmonary complication is the main determinant of poor outcome in patients who have scleroderma patient. As we said, that those patients, they might have intrinsic cardiac dysfunction, and they have stiffness of the pulmonary arteries, leading to what we call impaired RVPA coupling. There might be as well remodeling in the small vessel more pronounced than other form of idiopathic pulmonary arterial hypertension. Goal-oriented, which is the green zone strategy, now is the standard of care. And remember that this has nothing to do with dropping the pressure. It has to do with improving the symptoms, the exercise capacitance, the biomarkers, the echo finding, and the hemodynamics. At the moment, we have many active signaling pathway that we are targeting: the prostacyclin pathway, endothelin receptor antagonist pathway, and nitric oxide pathway. And as we said, uh, the the standard of care is really to have upfront combination very early in order to improve the outcome in those patients. Hemodynamics and cardiac MRI maybe should be used more in CTD patients, because as we mentioned in the first talk, that right heart cath might underestimate the severity of those patients, and you would like to have a strategy to assess RV, basically ejection fraction, stroke volumes, that will be done best by the cardiac MRI. And with that, I would like to thank you very much for your attention.